Hi everyone, my name is Sarah Barnes and I'm going to be talking to you about the cervical distraction test. Today we'll be going over what cervical radiculopathy is, how the test is actually performed, we'll have a video demonstration of it, we'll go over what studies have concluded about the test, and then we'll end with some practice. In a quick review of anatomy, there are 7 cervical vertebrae encompassing the spinal cord. Between each cervical vertebrae, a nerve root escapes through the intervertebral foramen. Sometimes the nerve roots can be irritated, causing symptoms in the neck and throughout the upper extremity. Causes of this irritation could come from a disc derangement, where the intervertebral disc protrudes and puts pressure on the nerve root, or more chronically from spondylosis, where the space for the nerve root shrinks, causing pressure. These are types of cervical radiculopathies. It's a nerve root injury, and for the majority of people, will present with unilateral symptoms of pain, weakness, or tingling throughout the dermatomal pattern shown in the image, or a myotomal pattern. The cervical distraction test I will explain is ideally used as a clinical diagnostic tool for this condition. The purpose of this test is to be able to clinically diagnose cervical radiculopathy. Although this is the main purpose and the one I will investigate further, we should also take note that Rainey et al. In 2009 used it to help develop a clinical prediction rule identifying patients who would benefit from cervical traction. So when talking about the diagnosis of cervical radiculopathy in our patients, there's currently no diagnostic protocol, with many studies indicating needle EMG as the current gold standard for the diagnosis. So based on the high complexity of that exam, there are high hopes for a clinical test to be both valid and reliable to be used more practically. With proper diagnosis and physical therapy treatment, there may be less incidence of invasive surgical intervention when it's not absolutely necessary. Although not clearly stated in many of the articles, it is important to keep in mind any precautions that we want to think about when we're performing this test on our patients. Now let's see how this test is done. With the patient supine on the table, you'll support the head under the occiput with one hand, while the other hand will hook around their chin. It's important to lift the pinky finger so not to compress their airway, and also be careful not to perform this handhold on someone with TMJ dysfunction or pain. Bringing the patient into a neutral cervical spine position, apply a small distraction force of about 14 kilograms for 30 seconds. This test requires the patient to fully understand what you'll be doing before you start. It's important to note, most patients with cervical radiculopathy will report a positive test within the first few seconds of the exam. A positive test is symptom alleviation during the distraction hold, due to the mechanical changes that this test causes in the spine by opening the space for the discs and nerve roots to rest comfortably. There are conflicting sources on the best way to perform this test. Some report the patient in sitting, but the studies reporting reliability and validity support the test protocol in supine. The 3 studies listed here all reported inter-rater reliability in the form of a kappa coefficient. This statistic reports the amount of agreement between raters. The closer to 1, the better. As you can see, the studies range between 0.35 and 0.88 agreement. Haney from 2014 stated that their coefficient may be so low because the 2 raters waited 24 to 48 hours between testing, which could be enough time for symptoms to change, therefore changing the results of the exam. Weiner, 2003, with the highest kappa coefficient, reported only 10 minutes between testers. Because of the time difference in Haney 2014, I would say this test has evidence of good to excellent reliability. This table summarizes measures of 4 statistics. Sensitivity is the ability of the distraction test to be positive when the person has cervical radiculopathy. Specificity is the ability of the distraction test to be negative when the person does not have cervical radiculopathy. For each of these statistics, the closer to 1, the better. With specificity between 0.9 and 1.0, we can say the cervical distraction test is great at ruling out cervical radiculopathy. Sensitivity measures between 0.4 and 0.44 are not as good. This means the test is not as good at ruling in cervical radiculopathy and may produce more false negatives. This may lead us to use the test in conjunction with another to be sure we're not missing someone who has a cervical radiculopathy. The following 2 statistics reported by Weiner et al. In 2003 are positive and negative likelihood ratios. Likelihood ratios help us to determine how much this test will increase or decrease the probability of cervical radiculopathy. A positive LR tells us how much to increase the probability of radiculopathy if the test is positive. 4.4 indicates a small increase in the likelihood of the condition. A negative LR tells us how much to decrease the probability of radiculopathy if the test is negative. 0.62 indicates a minimal decrease in the likelihood of the condition. In conclusion, the distraction test is quick and easy to perform with acceptable reliability and validity. It may be beneficial to include other tests in the form of a cluster identified by Weiner et al. In 2003. This cluster could have psychometric properties further investigated to make sure validity is sufficient. It may be beneficial to determine what position the patient should be in also during this test to provide the most accurate and reliable results. Based on review of the research here, I think the test is acceptable to continue using in the clinic. Here are my references, and now if everyone can find a partner, we're going to practice.